Hi everybody, my name is Dr. Scott Giacomucci. I'm the director and founder of the Phoenix Center for Experiential Trauma Therapy in Media, Pennsylvania. I'm board certified in clinical social work, in sociometry, psychodrama, and group psychotherapy, and my specialty is in trauma and traumatic stress. I'm really excited that you found this video, and I hope that you do find it helpful in your work. So in this video, I want to talk a little bit about post-traumatic stress disorder and provide an overview of what PTSD is and the 8 different criteria needed to meet for a diagnosis of PTSD. One of the ways that I like to think about PTSD is that it's simply a normal response to an abnormal situation, and that PTSD is a lot more common than we think it is. It's quite often misdiagnosed. There's a lot of other disorders that look a lot like aspects of PTSD. One simple example is ADHD. When we don't know about a previous traumatic experience, the hyperarousal that comes with PTSD, the constant looking over my shoulder, not feeling safe, being on alert, it looks a lot like ADHD. So I think PTSD in some ways is a often misunderstood diagnosis, though a diagnosis that's becoming more and more accepted and more conscious within the mind of our society. So PTSD actually wasn't recognized as a diagnosis until 1980, which was just about 40 years ago. Back then it was only used for military veterans. And even now, I still interact with clients and sometimes professionals who still hold that belief that PTSD is a diagnosis reserved for soldiers coming back from war, which couldn't be farther from the truth. Anybody can experience PTSD. It doesn't have to be just from war trauma, but really any type of trauma and even different adverse experiences can lead to PTSD. So this brings us to the first criteria of PTSD, which is a stressor needs to be experienced. There's different types of stressors that can qualify for this first criteria. One is direct exposure and experience to something overwhelmingly stressful or traumatic. Something like being exposed to death or having your life threatened, serious injury, any kind of sexual violence. This would be direct exposure to trauma. A second way of meeting this criteria is witnessing someone else experience something traumatic. A third way is learning that a relative or a close friend was experienced to trauma. Interestingly, in the most recent update of the DSM-5, they added this fourth criteria, which says that, this fourth option for meeting criteria 1, which says that criteria 1 can be met by professionals who indirectly experience repeated exposure to distressing details of trauma experienced by someone else they encounter throughout their professional duties. So this opens up the door for professionals who experience vicarious trauma to be diagnosed with PTSD. This would include police officers, firefighters, emergency responders, paramedics, therapists, lawyers, social workers, or caseworkers, really anyone that is working with trauma survivors can meet a PTSD diagnosis based on repeated vicarious trauma. So this is criteria A, the first criteria, experiencing the stressor. The second criteria needed to meet for a diagnosis of PTSD is about intrusions or re-experiencing. So this is what we normally think of when we think about PTSD. This is the flashbacks, the night terrors, the unwanted and upsetting memories that involuntarily show up for folks. The emotional distress related to reminders of a traumatic experience. The third criteria for PTSD is about avoidance. So I think it's only natural that after experiencing something really painful and difficult, that somebody might try to protect themselves from anxiety by avoiding thinking about that experience, avoiding the feelings related to that experience, avoiding reminders or people associated with that traumatic experience. So criterion C, in terms of PTSD, is about avoidance. The fourth criterion is reserved for negative changes in moods and cognitions or belief systems. So often after experiencing trauma, one's sense of themselves becomes distorted. One's sense of relationships and the world becomes distorted. Sometimes someone loses interest in things that used to interest them because of trauma. They feel isolated or disconnected from positive experiences, positive memories, positive emotions. It's quite common for trauma survivors to blame themselves for trauma that they experienced that they had no responsibility in. So this fourth criteria is about changes in mood and changes in belief systems. The fifth criteria needed to meet for PTSD is about arousal and reactivity. So maybe the most common is, commonly talked about at least, is hypervigilance and hyperarousal. That after experiencing something traumatic and feeling like we have lost a sense of safety, it would make sense that we're looking over our shoulder, we're startled easily, we jump when someone sneaks up behind us or someone puts a hand on our shoulder, or when there's fireworks or loud noises going off. This is about the nervous system being on edge, overactive. It's really more of a bottom-up symptom or cluster of symptoms, not something that starts with conscious thought, but really something that starts with the nervous system responding to external stimulus that relates to the trauma that was experienced. It's quite common for trauma survivors to have difficulty concentrating, difficulty sleeping because of this, difficulty with physical touch or intimacy. This increased arousal and reactivity in the nervous system can look a lot like aggression, irritability, destructive or self-destructive behaviors. This is the one that I feel like sometimes makes it harder to diagnose PTSD accurately, in that someone who has experienced a traumatic experience and is having difficulty concentrating or sleeping is hypervigilant. It might look like they have ADHD, or it might look like they have other executive functioning issues, when really it's stemming from the trauma that they experienced and the traumatic stress that they continue to experience. So the next criterion, criterion F, is about the duration of these symptoms. So in order to classify as PTSD, these symptoms have to last for more than 1 month. The next criterion is that the symptoms have to cause distress and impairment to one's ability to function in the world. They have to be significant enough to make it difficult for someone to work, to make it difficult for someone to be in relationships, to cause significant distress in one's life. And the final criterion is that we've ruled out that these symptoms might be caused by medications, by substance use or alcohol use, or by other medical conditions. So these are the 8 criterion of PTSD. In terms of diagnosing PTSD, there's also a few different specifications that can be used. One is a dissociative specification, which describes someone who's experiencing all the PTSD symptoms I described, as well as depersonalization, derealization, and dissociation. So it's more of a severe disconnection from oneself, from one's experience, from one's feelings. I I sometimes think about dissociation as being part of that avoidance cluster of PTSD, in that it's a way that we avoid feelings or thoughts related to the trauma. And I would argue that dissociation is one of the most common ways that we try to protect ourselves from trauma. If you think about it, it's really a creative way of doing so. If I can't escape physically from a threatening or traumatic or anxiety-producing situation, I'll just escape mentally and emotionally, detach from my experience. So I often like to think about PTSD symptoms as creative adaptations or as defenses, ways that we consciously or unconsciously, or ways that our body tries to protect us. Tries to protect us from danger or threats that we experience in our environment, or tries to protect us from memories, from feelings, and from sensations. So, in many ways, PTSD is the feelings, the sensations, the thoughts, the images, the experience of the past showing up and manifesting again in the present moment. PTSD perhaps is one of the least pathologizing diagnoses, in that it's less focused on something being wrong with you and more focused on asking what happened to you. I like to stress to the folks that I work with that PTSD is quite common, and it's a really normal response to an abnormal situation. It's your body, your mind, trying to protect itself, trying to prevent future trauma, and trying to adjust to the overwhelming experience that you had, trying to process and make sense of the experience. It's also not uncommon for PTSD symptoms to have a delayed onset. Somebody might experience a traumatic experience and not have any traumatic stress related to it for months or even years, and later for these symptoms to show up in their life. I think this is especially common for the clients that I work with who struggle with issues related to addiction, substance use, or alcohol use, in that these addictive behaviors are ways that we detach from our body, detach from our experience, block out memories, disconnect from feelings. So when I'm working with folks who are in recovery or abstinence from substance use or alcohol use, it's really not uncommon for them to start to experience some of these traumatic stress reactions in the first few months or even the first few years of their recovery. PTSD and substance use and alcohol use disorders really go hand in hand. They're some of the most common co-occurring disorders. And it makes sense when you think about it. Alcohol is a depressant of the nervous system, and many of the symptoms of PTSD are about the nervous system being overactive and on edge. So alcohol sometimes works really well at numbing the nervous system, at calming down the nervous system, as do many narcotics. Of course, the problem is that they cause other problems and create other consequences in our life when we use them. So I say that just to acknowledge that substance use, alcohol use, and PTSD really go hand in hand. Nearly half of the folks diagnosed with PTSD also struggle with substance use and alcohol use. Somebody with a substance use disorder is 7 to 12 times more likely to also meet criteria for PTSD than someone that does not have a substance use disorder. So in another video, I'll be talking about the connection between addiction and trauma and how they seem to exist in a cyclical relationship, in that they just fuel each other in this vicious cycle. So I encourage you to check out some of the other videos on my page here. And if you're interested in psychodrama specifically, which is one of my specialties, the book that I recently published, it describes a way of conceptualizing PTSD through psychodrama's role theory, using the trauma triangle as an operational definition of PTSD in action. And you can read more about that in Chapter 7 of my book, specifically on the section focused on the therapeutic spiral model. So I'll put a link to that in the description below. My new book is entirely open access, which means you can access everything for free. So I hope this was helpful. If you did find it helpful, feel free to subscribe to the channel or leave a comment below about what was helpful about it. I would love to hear from you and love to hear how these videos could be improved. Also, if you have suggestions. Thank you.